Now I think that it's a good time to have a scientific sessions, and it's my great honors to invite the first speakers, my dearest friend Ali Syam. Professor Ali Syam is going to give a talk in one of the challenge sessions in this morning. He's going to talk the year in reviews of the gastroenterology. I think he can work a lot. And Professor Ali Syam, for briefly, he's the current president of the Indonesian Society of Gastroenterologists and the current deans of Faculty of Medicine in University of Jakarta. Ali, state is yours.
Okay, so yes, very good morning. So thank you for inviting me, Professor Takon and also Professor Parucha. Yeah, we're happy here because our senior in the APIS come to this important meeting. Now, I just know that this meeting actually under Tamasat. So I know that why Ratakon invite me because I'm also academician and I'm still the Dean of Faculty of Medicine. Thank you for inviting me. Okay, so actually this is hard to me to how to explain about what's going on about the gastroenterology now. Yeah, okay. So why we are here? Because I think the gastroenterology is an evolving landscape. New medicine come, new technique come, so that's why it is a very interesting we work in this area. Okay, I think this is a good review, systematic analysis of the global burden of the disease study, actually from 1990 to 2019, published in the Gastroenterology, mentioned about the global trend in the digestive disease. Okay, we can see here that the age standardized death and daily rate significantly decreased over the time period. And also the decrease in age standardized incidence was less prominent. Means that we work hard to overcome the problems of the disease, this disease. So that's why we can, decrease the incidence, also the deaths of the disease. Okay, how about but in global trend in the digestive disease, so in this picture, so the prevalence increase, yeah, the 35% of prevalence and also 18.2% incidence and also 14.2% death. So we have still problems how to, to decrease the deaths of the disease of the digestive disease. Okay. Yeah, we see what kind of digestive disease burden in Asia. We can see here a picture that 52% from cirrhosis and other chronic liver disease. We still have problems with this disease. And also we can see another thing that upper digestive disease here, 80%. So this is our problem. I mean, this is the problems now that we face. We have still problems with the cirrhosis and other chronic liver disease. Also, with patients with the fatty liver come, and the incident, the prevalence increase time by time as well. And also the complication of this disease as well. Okay, so this is clear picture that mentioned that the cirrhosis and other chronic liver disease constantly rank #1 in all Asian nations. This is specific for Asian. And upper disease, digestive system disease, #2 across most countries, also in Indonesia as well. And I mentioned about the gallbladder and biliary disease, #3, #4, depending on country. Appendicitis still problems, pancreatitis still problems, hernia, and other disease, digestive disease like IBD, also vascular intestinal disorder. Okay, now we talk about the GERD in the era VCAP. So, yeah, I know from the Professor Ratakon that one of the big sponsor here from Takeda for Sinti. So that's why I must mention this about the PCAP, so the importance of PCAP. Okay, this picture mentioned that the GERD in the era of PCAP, rising burden and lifestyle risk. You know that the quality of life decreased because of GERD. So also the global GERD prevalence rate now 125.6 million in 2021. And then the incidence and the prevalent case rose by 80% and 80% now. So also I mentioned that the GERD burden increased with age in 15 to until 49. So this is our problems. And lifestyle and modifiable risks like alcohol use, still problems, smoking. In Indonesia especially, 1 of 3 adult smoker, and with a high, body mass index is a major modifiable risk factors for digestive disease in Asia. Yes, also urbanization, dietary change, and physical inactivity drive the obesity epidemic and increasing risk for GERD, fatty liver, and metabolic disorder also in our region here in Asian countries. Okay, but lucky for us because we have a PCAP now. We have ponoprazan, tegoprazan, fexuprazan, carfeprazan, and revaprazan, and 2 PCAP, ponoprazan and tegoprazan available now in Indonesia. Maybe in another, maybe next month or maybe next year, the fexuprazan also come to Indonesia as well. Why? This medicine important for our GERD patient because it is rapid, reversible, powerful acid inhibition. Okay, so back on the mechanisms, the difference between PPI and PCAP, we can see that the 4 PCAP actually non-pH dependent, act on both active and active pumps, and also bind reversible and ionoclip to potassium binding site, blocking hydrogen potassium exchange. And also again that the PCAP rapid onset and sustained acid suppression compared to PPI. So that's why yesterday we mentioned that maybe in our next consensus PCAP maybe will replace a PPI for some condition. Okay, thank you for Justin who made good contribution in these papers and then mentioned to see that from this meta-analysis we can see that ponoprazan, because we talk especially for ponoprazan here, that the healing rate of erosive esophagitis superior than PPI. Okay, and also for eradication. Ponoprazan is superior to PPI in first-line Helicobacter pylori eradication. I got information from Sensei Yamaoka Sensei that now in Japan, first-line treatment for eradication using PCAP than PPI. So, but actually, our consensus mentioned about that, but the problem is because you know that the PCAP still expensive than PPI. Okay, so from this meta-analysis, we can see that ponoprazan superior than PPI. Okay, the eradication rate 91.89, see, compared with the PPI. Okay, so also we have make review using the tegoprazan to see as for the first line eradication of Helicobacter pylori. Actually, it's an analysis of randomized control trial that some friend from Korea also contribution for this paper. Okay, actually we can see that the eradication rate were higher with tegoprazan. Maybe it's still question because only 83.4%, but in this meta-analysis we just compare between tegoprazan and PPI here, that the statistically significant eradication rate using the tegoprazan and side effects were similar, indicating the comparable safety profiles. Okay, again, that tegoprazan has potential as a new alternative for first-line therapy of Helicobacter pylori, especially in Asian population. Okay, so also here to see that the fexuprazan once daily, so non-inferior efficacy and safety to esomeprazole 40 milligrams once daily. Okay, yes, in Gastroenterology 2024, that the AGA also published about especially to integrating potassium competitive acid blocker into clinical practice. I think we have a good, figure here to mention that what is the position of PCAPs, that that may be used, yeah, for some conditions, especially for erosive esophagitis, and should be used for Helicobacter pylori eradication. And thank you because for these papers refer from our papers about the meta-analysis of should be used, so that Takeda must be thanked to me and also to Justin because of this paper. Okay, now we talk about the IBD, rise in Asian and therapeutic advances. Yes, we know many, I think that the Asia IBD group is, very strong and also good, collaborate with each other and then publish a good paper about the prevalence so that the IBD in Southeast Asia, low but rising incidence. This is important message for us here in Asian region. But the problem is the management of IBD, we need the biologics and also small molecules, still expensive. And then for Indonesia, especially, our public insurance cannot cover for biologic and small molecules. But many study mention that it works for our IBD patient, like vedolizumab over gut selective immune modulation with favorable safety, for example, and also anti interleukin 23 agents represent the newer biologic wave aiming to deeper remission and also mucosal healing, for example, and also for JAK inhibitors, said that the intracellular to block multiple cytokine signaling pathway, offering oral route convenience and non-humidity. So I think now the modern medicine come for our IBD patient now and future. Okay, and then also some consensus change the treat to target paradigm that aim for clinical remission and endoscopic and ideally etiologic healing, not just symptom relief. And also, we develop how to therapeutic monitoring, and also now come to about the biosimilars and accessibility. So this is good for our patient. And emerging direction to review, highlight the future strategies such as immune reset therapy, microbiome. So many center work in this area. So this is, good for our IBD patient in the future. And now also using the AI, see that the AI-driven analysis of endoscopy, histologic, many center using this as well and develop to study to using AI. Also the radiologic data will support earlier diagnosis, that we also use the USG, so also quite challenging for how to, monitoring of the treatment. And also the predictive models will assess clinician in choosing the right drug for the right patient and the right time. So this is a good area as well in our field in gastroenterology. And now we talk about the fecal microbiota transplantation and microbiome revolution. So we know that the FMT restoring the microbiome. The human gut microbiome is a vast ecosystem of trillions of microorganisms essential for digestion, immune balance, and also disease prevention. This biosis, we talk about this biosis everywhere, about the brain-gut axis, lung-gut axis, liver-gut axis, everything's always connection with the gut. So it is good for us as a GI doctors and also researcher in this work. And now fecal microbiota transplantation restore microbial equilibrium by transferring stool for healthy donors to recipients. Okay, how they work. So a quick historical perspective. Start from Eastman et al. For modern FMT for pseudomembranous colitis at the time. Okay, and then success for recurrent C. difficile infections. Now investigated in ulcerative colitis, metabolic, and immune-mediated disease. Okay, what does it matters? You know, reported clinical success rate 80 until 90%, particularly for recurrent C. difficile infection and emerging indication in IBD and metabolic disease. So we must work hard to do with this FMT, if it is work in IBD or metabolic disease. And generally safe. You can ask to Ratakon about this because I know it's a very, good paper and also have a good research in this area. Represent a paradigm that from drug-based to microbiome-based therapy. Okay, I must show these pictures. This is important for us here, that the efficacy of encapsulated fecal microbiota transplantation and via rectal enema or for irritable. This is a beautiful picture so that this really FMT work in our patient. So that's why maybe sometimes we need to import the FMT from Thailand because it is work for a Thailand patient. Okay, thank you very much. Thank you, ladies and gentlemen. So, GERD, new era of acid suppression, potassium competitive acid blockers, faster, stronger, and more sustained acid inhibition than PPI, improving symptom control and also nocturnal relief. About the IBD, we know that the advancing toward precision therapy. I mentioned that the biologic, small molecules, and reserving care, the future lies to treat to target strategies, drug monitoring, and biosimilar access. And the last but not least, about the microbiome, I think, restoring balance from within fecal microbiota transplantation represent the next frontier, rebuilding the gut ecology and expanding potential for metabolic and immune modulation. Thank you for your attention. Kabun.